Last hour of this whole series, and I'm really thrilled and pleased to have some representatives here from Galveston County that will talk about their health care and the types that they get, some of their hopes and fears, I guess, is one way I'm looking at it. How this came about real quick is that I approached Michelle Serapina, who you may know. She's a director of OLLI, the Osler Lifelong Learning Institute, and just asked them, this was my idea, do you think it could work, and what do you think we can do? And she loved the idea, and she just thought she'll get people, and she did, and they're in front of you here. I've talked with them about some questions and what we're going to be discussing about healthcare, and it's going to be relatively informal. We'll have time for you to ask them questions based on some of the things they talk about. And so we're going to move on to that real quick. Okay. First, of course, I'd like to thank you for being here. All right, it's real special, and I couldn't think of a better way of ending this series than to have some of your perspectives. So just real briefly, we're going to be talking, and you could just use this for the microphone. You could start with just saying something about yourself, introducing yourself, a little bit about your health and how you keep yourself maybe.
I'm Al LeBlanc. I'm an OB-GYN by background. I was born and raised in Beaumont, and went to medical school here at the UTMB. And as a part of my career here, I ran the hospital for about 10 years. And I'm now 80, so I feel like that I'm more than fourscore. So that's good that my health is as good as it is right now. I think the reason that Michelle picked me, however, was not from the physician background, but because of how much I've utilized the system. Jim Thompson, who used to be the chair of surgery here, said he and I personally were trying to wreck Medicare with as many illnesses as we had. But part of what I look at as the delivery system is the fact that I have had an aortic valve replacement and a coronary artery bypass done at the same time. I've been on warfarin for 15 years, which is a testament to being careful about taking your medication correctly. I had bilateral knees done 12 years ago. I had a paraspinal abscess with a septic shock. I was in the ICU here for about 3 to 4 weeks. I had diverticulosis with a major bleed secondary to an overkill with the warfarin. And I come from a family that has, my father had 12 sibs. Our family had 6 sibs. My wife's family had 6 sibs, and we had 6 sibs. So I've had to arrange, when you're a physician, you arrange the health care for the extended family. So I've got to experience more than UTMB healthcare delivery, because some of them are most appropriately placed somewhere else. I did, as part of my career, help develop with Dr. McGanity the perinatal healthcare system in East Texas, which involved going to a lot of the communities that I think the current audience comes from. And whenever we were asked, UTMB was asked to take over the care of the prisoners, which were mostly an East Texas phenomena at the time we took it on, UTMB was not asked, but told that it would take on the inmate care. And it has been a sort of a capitated system from the very beginning, and you can see some of the differences in the way that medical care is paid for if you deal with indigent patients and if you deal with prisoners as well as general population.
My name is Ellis Shook. I have nothing to do with the medical profession. I came from the broadcasting industry of all things. I am not a native Texan. I moved here in '03 after I retired. I didn't retire until I was 72, which I thought was a pretty good deal. And moved here because my wife was, her health was failing. And so we needed a lot of health care, and finally found it relatively easy to get. One of the things I can say about being in Texas with medical people, they are always friendly and helpful. I've never found a nasty one in the business. one of the problems that I found when I came here was I needed a regular primary care physician, and I lived out on the Stewart Road area, and I'm not sure how long that facility out there has been open, but I've been going there, I'm going to guess, for the area of 5 years, and I've had 5 primary care physicians in a row. And stability in that area, I don't know if it's common to UTMB, is very sad, because I don't want to have a changing, rotating doctor. So that type of thing needs some fixing. Otherwise, I'm very happy living in this part of the country. Michelle Sharpina has really done a wonderful job for seniors through the OLLI, which is the Osher Long-Term Learning Institute, and it is really wonderful. I thank God that my health, frankly, has been very good. I've never had any surgery, and I've never had a prolonged hospital stay. I have a lot of aches and pains, and I'm older than you are, sir. I get a lot of compliments that I don't look at, but I am 84. And I'm very happy with the life that I have here. And I guess I'd be happy if you would ask me questions about things more than me sitting here and just ad-libbing, because coming from the broadcasting business and starting out as a disc jockey, that's what I'm prone to do, including telling bad disc jockey jokes.
My name is Phyllis Southern. I'm a BOI, born on the island. I am retired from here. I worked in labor and delivery for 16 years. I had to take a medical retirement. I have spinal stenosis. I've had surgery twice. I and all my family have hypertension that I'm being treated for. I just recently was discharged from here. I have 2 sons. I am divorced. My oldest son passed away of lupus. He was 14 when he was diagnosed. He died at age 20, 3 days before his 21st birthday. My second son was born premature. He had a meningocele at the base of his spine. He's had numerous surgeries. We've gone through quite a bit. But by the grace of God and the help and the medical treatment that we sought and received, he's 37 years old and doing well. Before the storm, they had to remove his bladder. We were displaced for 9 months. We lived in 3 cities, 4 shelters, 2 hotels, and a mobile home before we were allowed to come back. We were in our house 2 weeks, and he had to have a colostomy. So between the 2 of us, taking care of each other and looking out for each other, and thanking God for this facility, it's helped us come through a lot, an awful lot. And I'm very grateful for the help that we've received here through the years. Through Ali and Michelle, I've been able to keep active when we have the time. It's very, very helpful to me because it relieves a lot of stress. I meet a lot of interesting people, and I just thank God that I'm here. Thank you.
Good afternoon. My name is Alison Parker, and as you'll be able to tell, I do not come from East Texas. I was born in Cambridge in England. I'm an identical twin. I weighed 3 pounds 6 ounces at birth, and I married a Texan, and so I've been here now for 27 years. my own health I consider to be very good. The past 3 years I've been really full care, taking care of my husband, who had developed Fuchs disease in his eye, had a transplant, cornea transplant, and the transplant took, but the sight did not. So he was a retired attorney. So he was continued to find difficulty in reading, because when you're getting older, your other eye doesn't adapt, even if it's a good eye as well. We considered that he had excellent medical care here. Before we found our doctors, we asked around, we asked friends, we asked relatives, who are the good doctors? And then we tried to get on their list. And eventually we did get on our list, and on their list, but it took a while, but it was worth it. And we've been able to stay, and like Alice, with the same doctors for many, many years. My husband also had heart disease, so I was seeing a cardiologist here on a regular basis, and then ultimately end-stage renal disease. And so we were seeing Dr. Beach here for some years, who actually made home visits and gave us his pager so that we could call him any time of night or day. And that was an enormous comfort. My husband died 3 weeks ago, so I'm a little shaky talking about healthcare. But I know a lot more about healthcare, taking care of my husband, than of my own healthcare, because I haven't as yet needed it so much. Coming to America was an enormous cultural shock in terms of healthcare. The first thing was going to a doctor and having to pay money. I remember my first, it was the interview with the doctor, and I was charged $100. And I went home and just was horrified and said, we can't go to the doctor because we paid for it. And if you're ever in a line getting prescriptions and you hear somebody talking loudly about the cost of the medications, they're probably from Britain, because if you're over 60 and maybe now over 65, in Britain you have free prescriptions, free medications. I've never paid a single penny in my life for medical care when I came here, aged 42. So it continues to be a continual shock. And my husband used to tease me and say, well, I always know when it's a medical bill, because you say, ah! And it's still true. And I have a lot of questions about the cost of pharmaceutical things. Maybe we'll come to that later, because I have to devise ways to deal with those. My own health I consider to be good. I'm a retired school teacher. I taught in England for a while, in state and in private schools. I was head of the junior department in a private boys' school. I also lived in Uganda, East Africa, for 4 years. I was sent by the British government to be an education officer there. So I taught in a multiracial school for 4 years, which was a wonderful experience. And then I came to Texas, and I taught, I was a social worker here for just under 5 years at UTMB, and got a healthcare administration degree, and then went back to my first love, teaching. And so I taught in Galveston Independent School District for 13 years. And now I'm both a member of the OSHA Lifelong Learning program, So I go to writing classes and other interesting classes. And I'm also on the faculty, and I facilitate one of the life story classes there. So I continue teaching adults. I've been teaching English as a second language for the last 7 years of my teaching here. So UTMB's clinics have become familiar places because of my husband's illnesses more than mine. I do have some arthritis, but it's kept at bay, and I've had some surgery. I had a hysterectomy here. I had cataract, one of them done, both very effectively and competently, and I'm very grateful for the services of UTMB. Thank you.
Oops. Might as well hold on to that. We're going to start there.
I'm sorry?
We're going to start with yours.
Oh, okay.
Are there any questions from the audience regarding the statements by the panel?
I would like to hear from Ms. Alison Parker, if you have any experience in, both healthcare system. Do you have any comparison as you are just, experienced?
Yes. Besides the cost, one is that coming in, I can't just go and see a doctor down the road, whereas being in a small country, it's much more accessible to be able to see a doctor. So you could always go and see a doctor. And if you felt ill in the morning, you could go to the doctor sometime during the day and have an appointment. You could go to morning or evening surgery. My father was a doctor in general practice, and we had surgery on the house. So having to make an appointment and having to go to hospital is very different than just going to the local surgery. So the ease of access, it was much easier there. Also, when you do get there, you're not asked the same questions every single time. They do have your name and your address and your telephone number, and you'd be going to the same doctor most of the time too. So that the doctor would be as much a friend as a doctor. And I think that's a very significant difference. And would tend to know your family. So you'd have the medical history would be much more known. You also would not have a blood test or tests every single time you went. You would only have them as needed, and that might be every 5 years. Another thing here too is that it seems as if you can only be sick between 8:30 on Monday to 5:30 on Friday, and otherwise you go to the emergency room. It absolutely staggered me that the people were pouring into the emergency room when they were not emergencies. It was quite clear to nearly everybody, and you paid more for them, and so the costs were high, whereas there'd be a family doctor on duty for the weekend for any emergencies. I think just being a smaller country is much easier to do these things. The distances are so far, but I still think that the sort of 5 o'clock shut off on Friday for being well is very hard, particularly as people get older or in ongoing chronic situations. But I also have found that the quality of care, particularly in the specialties, has been superb. I have a brother who had a sailing accident in England and was able to come here to the transitional learning community where they do head injury and brain injury. And they were far more advanced at that stage. So for that, we were very grateful. The renal care and the eye care that my husband had here was superb. So the specialties seemed to be very good. I didn't find myself afraid to be ill in England, but here I find people afraid to be ill. And that's a tremendous added stress when you're already sick. So, and that has to do with costs, with transportation, with just the whole drama of, I think the whole drama of coming to hospital when you're sick. That there needs to be other places than hospitals to come to for the lesser things, that hospitals seem to make sense for the big things, but for the smaller things, it's daunting. I think of it meant.
As caregiver, right, for your son, do you talk about that a little bit in terms of some of the challenges and and how you also take care of yourself while also taking care of your son?
Yes, it's challenging. It's very challenging. It's hard to make plans to do things because, it's prone to infections a lot. Before we left, before the surgery for the bladder, we had to straight cath every 4 hours. So everything had to be done in a time frame. I had to plan everything that I did. And trying to work, I had to work the night shift because both of them had numerous doctor's appointments, before my son, the older son, passed away. We had doctor's appointments just about, weekly. We were here. If not here in the clinic, then there would be things happening that we'd have to get to the ER about. So it's challenging, but when you have special children, it's really, you don't think about that until you look back and you wonder, how did I get through this? How did we make it? To me, it's an everyday thing, There are other things that happened. I was blessed to get a house of my own. My brother and my mother lived together, and I took care of them too. My brother he had lung disease, COPD, and he was going blind. My mother had bronchitis and different things going on with him. And even though I have family, no one stood up but me. So when I was blessed with the house, I asked them to move in with me. And both of them have since passed. My mom was in ICU for 3 months. I was lucky enough to have people that I work with that were so good. I went on a family leave, and they did a lot to help us. I would get up in the morning and cath Adrian at 7, get to the hospital, leave at 10:30, get back, cath them at 11, go back to the hospital, leave again and come and make sure that they both had something to eat because my brother didn't see well. Cath him for 3, go back, same thing at 7, make sure they had supper, cath them and go back. At 10 o'clock, I would come back. If my mother had a good day, I would stay home and rest and sleep the night there. If she didn't, I slept at the hospital. And I look back and I say, how did I do this? God was truly with me, giving me the strength and the courage because as I get older, I wonder, can I still face challenges like that? But you take it a day at a time, and you pray a lot, and you just, you just have to be strong and be willing to stand up to any challenges that come along. Because they do come, and to us, they come frequently. I call them my neighbors, because they're always knocking at the door, But we make it. and he's happy, and he's a great kid, even though I was told not to call me kid anymore because I have a mustache. So, you know. But we made it.
He's also very lucky.
Thank you.
And I have to ask Ellis, I mean, 84, great shape. I'm sorry, but how do you do it? I mean, it can't be, genetics, you know, we know that, but.
Well, I would say luck and the grace of God, but I really work hard at taking care of myself. Very simple things like beef once a week. I run 3 days a week. Now, I can't run 1.75 miles, which is my present route. So I happen to live on Seawall Boulevard. And as you'll notice, the steps going down to the beach, they're roughly 100 yards apart. So I jog between one set and then power walk between the next set. And when I get back, my heart rate is up to about 125. My normal heart rate is roughly 60. I do calisthenics 3 days a week. And with the calisthenics, I started to develop a little bit of a balance problem. And my doctor, I do yoga 2 days a week also. And the doctor said, "Will you drop yoga and start taking Tai Chi?" Well, I don't know if you're familiar with Tai Chi, but its major emphasis is balance. And before you could take a Tai Chi course at Ali, you have to pass a minimal test of balance. And so I took that course twice, and I told you I do calisthenics 3 days a week and stretches, but right after that I do balance practices. And I now can stand on one leg and move over and stand on one leg and do pretty well all by myself. But these are the things I think keeping busy, reading, keeping your mind busy, are things that keep you healthy. And I just do a lot of that. And I would also like to comment about the caregiver. I was a caregiver for my wife whose health was going downhill very quickly. She was using a walker, and I lived in Friendswood for 2.5 years before I moved here. When she fell, I don't know if you've ever done this, but try to pick up someone who is flat on the floor. You'd have to be a muscle builder to be able to pick that person up. I had a deal with my wife where I said, I am going to drag you. Now, if it hurt her, I wouldn't do it. But she got used to that. And you can't take someone who is on the floor and take them to a chair that moves. It has to be a sofa or a bed. I was on a first-name basis with EMS people in Friendswood because I called so often. And they would come, pick her up, put her on the bed, and she'd say thank you and get up and walk. But the wear and tear on a caregiver, it is very stressful, and I've never come across any medical support for the caregiver. It may be out there, but I never found it. And when my wife started talking about, I want to die, and says that over and over again, she had no feelings in her fingers. They tingled all the time. She wore hearing aids, and finally I had to put them in because she couldn't find her ear. And I loved my wife very, very much. We had a wonderful love affair. And she said, I want you to stop waiting on me. I said, honey, I'm not waiting on you. I'm doing this because I love you. But that puts a lot of stress on and the caregiver thing is just absolutely beyond belief. So I guess that's all I have to say on that point. Incidentally, in the broadcasting business, I had a chance to do a lot of community service. I was a general manager for the last 30 years of my broadcast career of 3 TV stations, not at the same time, that's in a series. And I got very deeply involved in my community, raising money. I have raised millions of dollars for the Muscular Dystrophy Association. It was only because I was a general manager and had the power to do that. And if you ever have a chance to do community service and see those muscular dystrophy kids and the suffering that they're going to be probably living with for the rest of their lives, do it if you can. It's a wonderful thrill and opportunity.
I also have been a caretaker, but not having to be as heavily a caretaker as either of your situations. But it has its own privileges. A situation that came up for us was that my husband was recommended that he have dialysis for his renal care. He had 15% renal function left. I should also say he was very fit. His whole life we jogged until he was 80, and then he had a very bad fall. The trees, that come up on the pavements, he had probably a small heart blip, faint, and smashed his face. So after that he walked. But he was walking for an hour a day, close to a month prior to his death at age 86, and was known as the walker. And Dr. Goodwin was his geriatric doctor, and he said, well, Jerry, most people who have your conditions wouldn't look like you or be able to walk like you, and it's because you've built up a residue with your exercise, and we tried to eat well, and except for the occasional ice cream and stuff. But healthy eating and healthy living really did make an enormous difference. But when it came to the question of dialysis, we went to the education about it, and it would be the nightly dialysis with, fastening on the plastic bag, and we went away and sat down here by the chapel and just looked, a miserable looking couple trying to decide whether to have dialysis. And he said, this is not how I want to end my life. With plastic bags every night, waking up, and also if he went to the restroom, which he would do, he had to put them back again, and he couldn't see well enough to do that. So of course I would be doing that. And I said to him, well, I'm willing to do that, but I have to tell you, I'm going to be a crab during the day. I can't go without sleep, because he just goes straight off to sleep. And I take time, if at all, to go back to sleep again. I said, I'm going to be a crab, not a wife. And we laughed about that, but then decided that he wouldn't have dialysis. And most of his doctors supported that decision. But there was one who didn't, and got quite agitated and pressured him telling him what a terrible death, a renal death was, and how really, this was not a good decision that he'd made. But every day in that last year, we were glad that he had not made that decision. And interestingly, his renal function did not deteriorate any further, although there was probably some deterioration close to the end. But the caregiving, I found, like you're on your own in a way, even though there are family, but family that either are too busy with their own families, they don't really have time to come and take time with your family or with us. And also we lived very independently as long as we could. We didn't want to sort of find other people. But it is very exhausting. I think that's one thing that's missing in the healthcare system is support for the secret caretakers. You know, the ones that always say, no, I'm all right, or I'm all right, I'm a bit tired. Well, read between the lines. When you see people being caretaking, there's so much more to it. And as Phyllis was giving those details about the timing, your whole life centers around the sickness and the care of that person. And you love them and you want it to be good for them. But I think the medical care has much to offer yet to that.
Good point. Okay, we're going to talk a little bit before I do that. Any questions, Sue?
I'm just curious if hospice was presented as an option to all of you, and Phyllis, not that your son is terminal, but your mother, and when the situation is terminal, is hospice presented as an option early on, or was it way too late down the road?
2 days before my brother passed away, that's when it was offered.
Yeah, that's sad.
4 weeks before my husband passed. Now, it had been offered a few days before. He refused it. And when it did come, when we signed on, it was the lady who did it was just superb. Got us all the services, got us oxygen, and very good on equipment. But after that, it was the nurse once a week.
Yeah, it's still,
Once a week when you're in crisis.
It still requires that you have a caregiver in
Yes.
the home. But there are hospices that have facilities as well, or
Yes.
if you're in a nursing home, they visit
Yes.
there too.
Which of
But
course
it's never offered soon enough.
no. And in fact, the pain wasn't dealt with soon enough.
Wow.
He was in an enormous amount of pain until just the last 2 or 3 days.
Just a comment about hospice. I think they are sensational. And I'm not sure I'm right about this point. They won't come in 3-4 weeks in advance. They're there because they know that you need help and the patient is terminal very quickly. I have had a cousin who the doctor said, you have 6 months to live. Her kids weren't happy with that and they called hospice. They came in and said, she has a week. She died in less than a week. So I'm a big supporter of hospice. I'm not sure that hospices are constant in their application of their practices. That I don't know about.
Most hospices are equal in terms of the services and how they're able to provide. I'm going to let Adele speak to that in a
Leading on the question, when was hospice mentioned? Do you feel you would have been ready for hospice before the doctor brought up the idea? And would you have been receptive to it at an earlier time? Because there is, if a doctor feels that death can be anticipated to occur within 6 months, hospice then can be called in for assessment and, if appropriate, services provided.
I would have welcomed it because I really needed the help. I really would have.
It wasn't offered, it wasn't suggested to us, although we knew about it. I knew about it. Well, we both knew about it. Yes, and also having been a social worker years ago. But we were doing fine, so we didn't actually need it until the later stage.
Yeah, I'd like to.
Thank you.
I'm sorry.
Just one quick more thing about it. Isn't hospice primarily for home care and not, for example, hospice did come into the nursing home to look at my wife. But I thought they were primarily for home care. Am I right about that?
Okay. Hospice is a service provided in the environment in which the patient is living at the time. So it can be a few days in a hospital, transitioning from, we've got this serious medical condition, we're anticipating death, and usually just like 3 days in the hospital while the family is deciding, are we going to go home with all of the caregiving issues surrounding the needs of our loved one? Are we going to look at a nursing home and go that way? Now, some nursing homes do not allow hospice in them. So, but if hospice is a service that you want, there are nursing homes that allow hospice in, and they're very familiar with hospice services. I've worked hospice in the past, and it's a service, and it's provided where the patient is physically.
And Houston has a hospice that's a facility, you know, and there's other places, Brazoria County and other places that have actual buildings and facilities.
Yeah, the larger hospices have residential locations.
I think it kind of shows me that I'm going to organize something for caregivers and hospice a little bit down the road.
Tony, I want to mention the cost of end-of-life care is so extreme when you spend 3 months in an ICU. And this should be an option that healthcare providers are giving to families and patients.
Right, you're right.
Yep. I'm not going to continue on the caregiver path, but and I don't want to.
We just have time.
Many of you are now by yourselves, and eventually, I do not have children. I'm originally from the Netherlands, so no brothers and sisters close around me. And I've worked in home care, and I've seen an awful lot of. It's not even loneliness; it is desperation and nobody to help.
Exactly.
When you reach senior level, you should have long-term care, an insurance policy that covers long-term care. And long-term care can be in an extended care or in a nursing home or in your home. If it's in your home, it's half the cost. But you should have long-term care, and if you don't, people, I don't sell insurance. But believe me, I have long-term care because I'm alone. And I would rather be taken care of, if I could, in my home than in a hospital or a nursing home.
But there are so many little organizational things that
I'm back with Ms. Parker. The affordability of care for long-term care policies is very expensive.
Yes.
What isn't?
I don't have long-term care. Okay, then.
We were and are still not in a financial position to really be able to afford much of anything. We are on our own, like I said, I have family, lots of family. I have a sister in Texas City, and she rarely came to see my mother. Everything was on me. Never a knock on the door, do you need a burger? Can I give you a break? None of that. So, but I learned early in life that I am in this world practically by myself. From the birth of my son and the meningeal and all the things we went through with that, with the fluid accumulating on it's just a lot. With my older son Vern being diagnosed with lupus, it didn't normally affect males, so they were looking at everything else, bone cancer, leukemia, all kinds of things. And it was just horrible, and I had to leave one to take care of the other. There's not a lot at that time, and I don't think so now, that addresses the financial needs of people who weren't able to pay.
I absolutely agree with you. One of the things in this community, to answer your question, is the program that we're all a part of, the OSHA Lifelong Learning, because it has yoga, it has Tai Chi, it has things for the mind for anybody over 55, and the cost is $25 for each 8-week course. And there are scholarships for those who can't afford it. And that's one really great thing that I think that is in Galveston. It's the social contacts that primarily keep your health. May I say something about prescriptions? Cost of prescriptions. I'm half Scottish, so you know, you're very careful. And as the prescriptions began to come in, that donut hole that Dr. Goodwin talked about, and it is something to avoid at all costs. And the way I found that we could do it was by checking that the medications that you received, that where you could get them on those $4 deals at Kroger's or Walmart. I found Kroger's, you didn't have to wait as long, and they're also, you get to know them and they're real kind to you. The mail order sometimes is good, but if you have something come up suddenly, you're stuck because you don't have the mail, can't do the mail order in the same way. One of the things I hadn't realized naively, and I found that hardly any doctors or nurses or anybody else, even the pharmacy people, really understood, that was that when you paid the copay, for example, if you have generics with Humana, it's $7 a copay. So you would pay $7 for the prescription, and then they may pay, they say, though I'm never quite sure about it, they say that they pay $31. And those two are added together so that you have $31 to $38, say. And that goes toward the donut hole. Now, the general perception is that it's as you pay $4 here, and $4 here, and $4 here, when you get to 1,700, I think it is this year, that's when and you're not. You get to the donut hole much more quickly. Pharmaceutical companies have doubled or tripled their prices over the last 2 years on my husband's medications. And there are things that get your patients to check with the pharmacy first before they pay, so that they can find out if they need to talk to the doctor about an alternative. We have found our doctors very cooperative at looking at an alternative. The new medications that you see advertised so widely on television are frequently the most expensive. And I found the nitroglycerin pills were not too expensive, probably about $60. The spray, and when they stopped working, the spray was suggested. That was $330. So you're very quickly, my husband got into half of the donut hole in 2 months this year. And then you're out of pocket yourself, and people can't pay when they get there. So finding sometimes doctors will give you a sample if it's a major medication. Patients can ask and see if they can have a trial to see if it works before they put out money. But it depends on your doctor. And we had good ones.
Lucky there. We have just a few minutes left, and I've asked Al to just kind of wrap up a little bit in terms of what we're looking at with healthcare. Possibly in the future, is healthcare reform going to be an answer for us? And we.
Jim Goodwin had an hour for this, so just kind of looking back at it. When most of us that grew up before the Second World War was over, experienced the type of care that was in England. Most of us had primary care. Our doctor was our friend. I can remember each doctor's name and how they took care of us. And after the war was over, then big technology began to develop, and there was the emphasis on trying to cure what wasn't there before. Some of them were wonderful miracles. I remember penicillin worked for everything when it first came on the market and so on. And techniques that right now, I can remember my wife's mother died from a cardiac myopathy, and she would have been salvageable with current techniques. So part of the price of medicine has been the fact that we've chosen to use much more technology. And I'd like to say also a little bit of something about having been in Japan for 2 years in the service, right after the Korean War was over. The Japanese people have a unique characteristic to them. They don't eat much meat at all. They walk every place. They don't ride every place. Well, I'm sure they do now in Tokyo and so on. But when we were there in the late 50s, early 60s, they did that. They took care of each other. There was no need for hospice and so on. It was a characteristic of the personality. Part of what we have in healthcare is a characteristic of our country and a characteristic of our location. When I came here to medical school, there were two alternate systems. One was for the indigent care and research, and the other was for the usual patients in the community. St. Mary's Hospital and a cadre of private physicians delivered primary care and secondary care, as Jim outlined on that. And the university was developing into a tertiary care center because that was what was expected of medical schools to do at that time, is to be able to train physicians in both the primary care medicine and also with the utilization of the current new technology coming along. I came to be a physician on the faculty here because, like Jim, I didn't love money. The worst thing you could do if you were a doctor, if you wanted to make points with your in-laws, was to go to academic medicine because you saved poorer than they did. But now that's not what's going on right now. And over the last 20 years, most of us that are at my vintage are concerned with what is happening to our physicians. Not their brightness and not their ability to use computerized medicine and so on, but their sense of what their purpose is in life. And I'm very concerned about the type of doctors we're producing if we don't, in medical schools, have access to patients that are particularly complex, like correctional health care patients are, or particularly difficult as indigent patients are. They're basically being written out of the scenario by which you learn to do medicine that is merciful as well as scientific. I hope that the healthcare reform changes that, because most hospitals really don't want a Medicaid patient in them, regardless if they are an indigent patient, even if they could pay Medicaid. They just don't want them next to the patient who expects not to be in the hospital with an indigent patient. So I hope places like UTMB will benefit by healthcare by having patients who they're able to financially take care of. State support of medicine is not, educational medicine is not as it should be. And but if all patients had medical insurance of some type, UTMB could return to its not worry about the bottom line education of physicians, nurses, and other healthcare providers. So I think my perspective of it from where I am is not just as a patient and not as just a facilitator for medical care in the family, but looking at what we are developing in the future of it. We need many more healthcare providers. There's no question about that, because our populations are growing so fast. We need to have some way in which medical care is less expensive than it is. We have to be able to support politicians who are putting caps on, not just selling houses at balloon rates, but also companies like the drug companies who are making excessive profit out of it, and in which, if we'd been smart, we would have bought our drugs to Canada and brought them across the border. We have a good friend. I think all of us are good friends with Sarah Palin, and because we know her over and her foibles over the thing. But she was in Alaska, and they went to Canada to get their medications because they were so much more expensive than in Alaska. So I think in a complex topic like this that you're trying to cover fast, that there are blind spots in our system right now. They're not at the high technical end, they're at the low technical end. Things like hospice and end-of-life care and support for home caregivers. And we're producing whatever we produce, and if we're going to produce all bottom liners in the pharmaceutical industry, in the medical industry, in the nursing industry, or so on, we will not have the type of health care we want. So I don't know if that's what you wanted, but
that's fine. Thank you. We could go on for quite a while. I need to kind of wrap it up, but I want to give everyone a chance to, if they have anything else that they'd like to add, if anybody has something that they'd like to say. Okay.
I work in the internal medicine clinic where we have maybe 10 faculty doctors and almost 50 residents, and I've listened and written down some of your concerns, and if there's any one thing each of you think is most important for me to bring back to my team, I would love to have that information and share that with them.
make sure all the residents know what the patient's first name is, how many children they have, whether they're married or not, and look at them as something different than a learning opportunity, as a chance to, by interacting with them as another individual, that they can increase the value of the medicine that they deliver.
My only advice is it is so complicated for the average person because it's basically a political problem. It could be made a lot simpler, as the doctor said, but try to sort it out, to think and to ask questions, because everybody I talk to has a different opinion and it's hard to make any decisions, which it leaves it way up in the air. And doctors may be able to help patients if they pass simple things on to them about being cautious.
One other thing, and it just hasn't come up, but I think it's important, and all of you know it's important, is self-education. When you get a medication, read everything there is about it. You will be the one who will pick up the problems more quickly if you were informed about the medication.
Could I ask you a question about that? I read that material and I say, my God, a lawyer wrote this. Because it's designed, and by the way, don't eat this, don't drink that, do this, and pretty soon they're covered if anything happens. So where does the education begin and the attorney?
Well, they certainly don't begin on TV ads, because if you watch a TV ad for a medication, 2/3 of the message is about side effects that they have to tell about.
Right.
1/3,
and that's by law.
And that's by law.
Want to think of it.
And I don't really think that reading the inserts that put with medications, because they're just a written television commercial. They have to do what they're doing. Go to the internet. If you don't know how to go to the internet, go to your library. They'll teach you how to get on the internet easily enough to be able to pull up the medications, and you can go to Wikipedia or something like that where it's a little simpler to read, and you can make some choice about it. Same thing is true as you wouldn't take a trip to the Middle East without checking with somebody that had been there before or knew a little bit more about it. But you go to doctors without knowing much of anything about it. You don't research it well enough. All of us have to see that a big part of our health care is us. And we are letting ourselves get less and less. Not everybody, but I'm going to give a commercial for Ollie too. When you get older, the thing that you miss the most is active intervention with people your age that have minds and that you can share with. And we wouldn't know nearly as much about medications if we didn't go to Ollie and meet people we hadn't had before who were taking a medication and say, do you remember this? I learn something every time I go to an Ollie thing, and it is, we are blessed in this community to have a program such as that. But most communities do have geriatric or senior citizen or whatever name is more appropriate to use. And all you have to do is be 55 to be an Ollie. That's pretty young, okay? But I think that there is a value to being a participant in your community, whether in volunteer work or whether to go to things like the libraries or Ollie offers.
Well, just to tell you how interesting Ollie is, my wife became ill and was hospitalized in January, and in effect, she was incommunicado until she died in April. Ollie rescued me and urged me to go to a ballroom dancing class. My ballroom dancing class partner was this lady right here, who was the first woman I'd held in my arms for 9 months. So we are old friends.
You want to say, answer her question?
Yes, Ollie has really helped me. I can think about other things. I can meet other people. I'm free for a little while, you know. And they've even embraced my son. Adrian and I took beginning Spanish together. And we had a blast doing it. We really did. So I'm thankful for the community. They're like extended family to me. I'm blessed.
To answer your question about for residents, treat the patients like people, like human beings. Well, it's sort of partly what Al was saying. So that they're real. And explain things in terms that are comprehensible and in lay language, without being condescending. I often wonder what the doctors are actually writing down in all that stuff there. I mean, I think they should read it back to us, actually.
Well, there's a new service. We're heading, everybody knows we're heading towards electronic medical records. And they're really a pain in the ass, excuse me, right now, because most of them are directed at recovering data that's necessary for billing purposes and stuff like that. They really are not what electronic medical records are to be about, which is an information passer, information retriever, and it allows you to be ill any place in the world, and your electronic medical record that you don't have to say what medicine you're taking every time you go to the doctor, and you don't have to give a list of your things that have happened to you, because you get older, you forget them anyway. But there is a program called My Chart that's just being brought up on the electronic medical record now, and you can go to your computer, and as old as you get, you can still use the computer at some level. There's not any age you can be that you can't do it. And if you have a grandchild, you'll do it better than you do it by yourself.
Right.
But you can go in there and look at what your lab test reports are, and you can look at the summary of your last visit to the doctor, or if there are any special instructions that go out. And so I think it is important for us, again, if we're going to get the best health, to invest a certain amount of time and effort ourselves in it, particularly in that. And that's a way to get information that maybe you didn't get. But I do think that we're not training physicians as well in the art of medicine as in the science of medicine. But we'll swing back the other way, I'm sure.
On that note, I'd like to thank our panel. Thank you for being here. This concludes the session, and we'll hope to see you next year.